Okay. I'd like to call this meeting of the Stroke Committee to order. And I'm going to just pass the attendance roster because none of you guys care about that. First up on our agenda is the Regional Advisory Council Data Collection Work Group. And that's Ron and Johanna. And Ron can't be here. He has an excused absence. He's currently doing his D&V survey as we speak. So can you give us just a quick update? I know there's not a lot. Yeah, but you can say that.
So there hasn't been any meetings or any information distributed. So.
Okay, and we're going to continue to work on that. I mean, it's very complex, and we've been trying to do it for a long time. So I would have everyone indulge us with patience in that regard. Next up is the subcommittee report on EMS stroke education, and that's Homer.
Yeah. Okay. Jane is not here.
No, and Jane's not here, but we can come back also.
You want to give her a few minutes? Yeah, and she can put that up on the board for everybody. Can we do that?
Yeah. So we're going to delay this until Jane gets here because we have some official stuff from the Department of State Health Services. The Stroke Survey Work Group Subcommittee is the same as number 1. And Ron isn't here for report on the Trauma Systems Committee Registry Work Group. Is there anyone that can discuss that? It's running right now?
There's going to be a pilot project that TSAD is going on. I'm sorry. One of the things that I attended the meeting real briefly. One of the things is that TSAD has agreed to be a poster child, as they put it, for a project to help improve reporting and trauma registry and so forth, and kind of ironing out some of the problems. That was presented to them today. I think Colin hopefully will be here in a bit and can fill you in. He's actually the one that's in charge of it. But it's going to entail just actually hands-on entry data problems and this kind of stuff, so that we can at least get folks being able to get the information in timely, and as we progress, then we can iron out other problems as they come up of maybe content or those kinds of things. So.
Okay, as we fly along, any liaison reports? Anybody go to any of the other committees? Nope, so we were sorry about that. Next, I have a report from the Texas Council of Cardiovascular Disease and Stroke. We didn't have a quorum last time, but we have changed some things at the TCCVDS. We're now having the Stroke Consortium is now meeting at the same time to sort of move together sort of the prevention component with the Texas Council of Cardiovascular Disease, which sort of coordinates and reports to the legislature. One of the things that I would tickle people with is what we don't have right now is really a rehab or rehabilitation component to stroke at a state level. And so that seems to be a void that hopefully maybe something can become self-organizing in that regard. What else? That's basically all. The next TCCVDS, there should be some more interesting news that I can't tell you about at this point. I can give you a bit of a legislative update in that the American Heart Association's bill to get with the guidelines for the RACs as a recording device for data seems to have stalled in committee. The bill to have money for stroke research and education projects throughout the state. That's still in play. And as you know, the legislative session is still ongoing, and there'll probably be an additional session. So at least there's some hope that we may have some money in that regard. Okay. So good. I'm running ahead of schedule. So I'd like to introduce Richard Klusnick. Dr. Klusnick is a neurointerventional surgeon at Methodist Hospital in Houston. They were the first comprehensive stroke center certified in the state, and there have been lots of recent advances and information that has come out, like at the International Stroke Conference in Hawaii just I guess it's a couple of months ago now. And because of all this, I thought it'd be interesting to have him speak, as well as Dr. Alberts and others, in regards to some of that information for people. So looks like you've got 30, 45 minutes until some of the other people get here. So please.
Well, thank you. Is the microphone on? Can you hear me? Yeah, thank you. Thank you for inviting me. Yeah, that was a pretty interesting meeting in Hawaii, and I was there for that meeting, but we're going to try to go through some things. Well, that's my partner, Dr. Diaz, down in the corner, where the two people have been there the longest at the Methodist Hospital. This slide here, this is written by Tom Tomsick years ago, the Rapid Evaluation of Stroke to Direct Therapy. So that is his trial, and our goal in stroke is to try to prevent things from going on. So we're there to try to get the bad things from happening and taking hold. And this is an EMS meeting, so hopefully your city is not like this, that you have two cemeteries and no hospital. We'll give a little bit of a history in the thrombolysis, the intraarterial thrombolysis. Of all of those studies and all the things that the only one that ever showed any efficacy was the PROACT trial back in the 90s for intraarterial R-Pro-UK. And the FDA demanded more studies after that, and the Cordis at that time said that we don't have the money to do it. So that study has stayed in limbo since the 1990s. And with that, we tried to move on to kind of, like Tom Tomsick said, is intraarterial stuff. Well, we had urokinase. We never know how much the dosage really was, but there's an M1 occlusion. And sure enough, we can get a microcatheter up there, and we can get that open. That's from the early 1990s now. And then from there, we actually went to retrievers. We used multiple retrievers that were not FDA approved. Finally, we do have some things that are FDA approved: Mercy, Penumbra, Solitaire Retrieval, and the Penumbra 3D. And as that video shows, everything is about the lure. Is you're trying to get after that clot, and how good you are, and what device are you using to get at that clot. And of course, if you're not using newer devices, you may not be getting what you want out of that. We start with the Mercy Retriever. The Mercy Retriever is a simple thing. It looked like a corkscrew. This is a Mercy Retriever case. It's an M1 occlusion. You can see the retriever in place, and we were lucky to get that clot out on that day. And there's the clot sitting in the Mercy Retriever. However, even after the new iterations of the Mercy Retriever, we always felt that the best thing to do if you're going to use a Mercy Retriever is pray. And because the thing, at least in a lot of people's hands, hardly ever worked. And the reason I'm going to tell you that is it's going to get clear as we get on to IMS-3. Well, the next thing that came out was the Penumbra aspiration catheter. And they proved that, that you can suck, and aspiration, if you're applying aspiration, does work. And this is a Penumbra aspiration catheter, and is designed to suck clot out and open that blood vessel. Again, this is historical because we're going to be talking about IMS-3. And here's the head-to-head combination between the Mercy and the Penumbra. Well, the Penumbra was an advance over the Mercy, as you can see. Device-related was less, procedure-related complications, intracranial hemorrhage was less with the Penumbra. So the Penumbra already appeared to be a better device than the Mercy Retriever. And then, of course, people started working on things that we call commonly a stent on a stick. So take a stent and put it on a stick, something that's not meant to be detached, and try to get clot. The ones that are FDA approved now, Solitaire, Retrieval, and Penumbra, as I'm going to tell you in a few minutes, is going to be under trial. And our goal as stroke people is to make the post better than the pre. Here's what the Solitaire Retrieval looks like. It is a stent. And the history of the solitaire retriever is that it was designed for use with coils in an aneurysm. You can use it to put coils in an aneurysm, and then you can retrieve this stent and pull it out. Well, lo and behold, they had a situation where there was clot, and they pulled the clot out, and hence began the solitaire retriever. This is one of our cases. Here, there's an M1 occlusion. You can see the whole M1 is out. The solitaire is in place. It's just in place, and it's already reestablished some flow. And there's it open. I opened it in 20 minutes. From the time that I punctured the groin till I get these pictures was 20 minutes total. So we've actually changed the paradigm in stroke with these new retrievers. And that's his MR at 17 days, where it's not a big stroke. It's only a small little basal ganglia stroke. Trevo is the Boston Scientific one. They all work on the same way. You deliver it, then you let it expand. Same thing for solitaire. You let it sit there for 5 minutes. That's what this clock is going to show you. You let it sit there for 5 minutes, and then it expands. Hopefully catches the clot, and then you pull it out. This is the 3D separator from Penumbra. So we're advancing on stent on a stick to not just have a stent that'll expand against the wall, but actually a stent that have stuff that stays in the middle. So it's three-dimensional to hopefully catch clot a little bit better. And of course, in January, February, we hit a wall, because 3 articles were published at that time. IMS3, Synthesis, and MR Rescue all came out at the same time, New England Journal of Medicine. And that's when the battle started, is we got this data from these 3 studies, and now what do you do with this data? And where do we go from here? So it's not the battle of titans, but it is kind of turning into a battle of titans where lots of people are interested. This is the IMS3. IMS3 randomized eligible patients who received IV TPA within 3 hours and either additional. Now, this is you have to be clear about this. They were randomized to receive additional endovascular treatment or IV TPA alone in a 2-to-1 ratio. Why a 2-to-1 ratio? That's a good question. If it's a randomized trial, well, I'm going to get to all the rebuttal points in a second. Primary outcome, ranking of 2 or less at 90 days. The study was stopped because of futility. Basically, that endovascular treatment did not offer any advantages. That was their study, no difference between the 2 groups, and no difference even if you were a bad stroke, the NIH stroke scores, and even depending on the time course of getting to them after you gave TPA less than 90 minutes or greater than 90 minutes. So it looks bad for endovascular treatment according to this study. Synthesis trial, this is the Italian group. They randomized 362 patients with acute ischemic stroke within 4.5 hours. Now, their study was IA thrombolysis with TPA, mechanical clot disruption with a wire or catheter, or retrieval, or a combination of any of those. So you can already see the design of the trial is flawed. You're using a bunch of different things. Not anyone is consistent in the group. And then they came up with the same point, that endovascular treatment is not superior to standard IV. MR Rescue, the mechanical retrieval and recanalization of stroke clots using embolectomy, is the only trial where they use within 8 hours, but they at least were using pre-treatment CT or MRI, and they randomized whether the patient had a penumbral pattern on the MR or CT, whether they can preserve brain. A favorable penumbral pattern did not identify patients who would benefit from endovascular treatment, nor was embolectomy shown to be superior to standard care. That was their bottom line. So 3 studies that, quote, say endovascular treatment basically is not superior or is equal. So basically after that, the proverbial you-know-what has hit the fan, because we have to look at these trials now and say, are they worthwhile or are they? So with IMS3, let's go and think about what is the future of mechanical thrombectomy. The stuff I'm going to tell you comes from 3 different sources, really, but this is a very good article in the most recent JNIS by Fiorella, Hirsch, Tarr, and Albuquerque. But we were involved in the initial rebuttal to the California Technology Assessment Forum, and I'm a board member of SNIS, and our president, Michael Alexander, drafted a rebuttal. You know what that is? The California Technology Assessment Criteria Forum Basically, for California decides what devices and things can be used in the state of California. Their recommendations will take hold, and they take hold to insurance. So if they were before IMS-3 saying that you shouldn't be using this, you can imagine what they were saying after the paper came out. And that meeting was held in California. All three major societies, Society of Neurointerventional Surgery, Society of Interventional Radiology, Society of Vascular and Interventional Neurology, all wrote rebuttals to the papers and all wrote rebuttal to the California Technology Assessment Form, and basically they haven't listened yet. All right, so let's look at IMS-3. The endovascular techniques, as we all know, are not designed to treat strokes. They're only designed for large vessel disease, which is the index disease. They're not designed to go after a small, tiny clot someplace in the distal MCA, or if the vessel has only a small amount of clot. They're designed to go after big stuff. If you're going to do that, you must exclude patients who do not have the index disease. This was not done in IMS-3. So patients who did not have the index disease were not excluded and put in the data, which throws the data off. Synthesis did the same stuff. 23% of all the cases randomized to endovascular treatment did not receive endovascular treatment because there was no occlusion on the angiogram. So there was no imaging basis for patient selection. So it's 23% of patients enrolled. Well, of course, where's the data going to come? If they're not even going to have the endovascular treatment, well, it's going to make it look like they're equal. 60% of cases randomized to endovascular treatment were older stuff, IA, TPA alone, and I'm going to show you why that may be a problem. The old ECOS device, which no one uses, and I've never used it in my life. The Mercy one, which you pray might work. And of the CTA-confirmed large vessel occlusions, there's a statistically significant 90-day outcome, even in their own data, and I'm going to show you that. Allocated treatments must be performed in the treatment arm. Again, these failed to do that. Again, that's the 23%, the majority are just screened on, basic CT alone. And patients with large vessel disease without large vessel disease were exposed to unnecessary risks. And the patients in the IV group received the full dose of IV TPA. Initially in IMS-3, the people who were going to potentially get treated with endovascular treatment only got 2/3 of a dose. So there's a dosage problem. And patients with angiographic occult or distal small vessel disease, they're going to do well with IV TPA. That's what IV TPA does. 40% of all the patients enrolled in IMS-3 had a Alberta Stroke Program aspects of less than 7, which correlates with a poor outcome. But you are including them in the trial, and you're including them in the group that may have undergo endovascular treatment. Well, it's not going to work. They already have potential strokes. This slide is directly from Joseph Broderick, who is one of the investigators from IMS-3. And he says the investigators are suggesting that basically endovascular treatment should only be allowed or reimbursed in trials. But this next sentence, that the IMS-3 doesn't support that the endovascular treatment is not significant. And he even does make the point that we are using newer things. That study used older devices. There it is, only study first generation or non-improved methods for recanalization. That's from his own trial. This, amazingly, doesn't make it into the paper that's published in the New England Journal of Medicine. It was only said at the study site, at the Hawaii meeting. These are his slides himself. He's the third author on the paper of IMS-3. So the devil in the details again. When you do an analysis of the subgroups, which baseline CTA was done, that's not reported in the main manuscript. But it is, again, when he's talking about stuff. And here's the data. If you did a baseline CTA and you prove that there's occlusion present and you use endovascular treatment, you have a markedly significant people who are now MRS 0 and 1 compared to IV TPA alone. Therefore, the results of their trial are not true. It's baseline CTA, we'll look at this. Basically, endovascular treatment, by his own admission, does confer a real benefit across the spectrum. There's the p-value. If you look at this data, well, it does. IMS-3 does have a positive outcome for endovascular treatment. His own paper, and this is stuff he presented in Hawaii. It's not part of their paper. People that were given IV TPA alone, and this is done by percentage of recanalization at 24 hours by CTA. Of course, big vessels, low percentage. Smaller vessels, you get a good percentage of recanalization. But those that are now given on the endovascular arm, the same thing. Look at this, 82% recanalized, 85, 88, 100% for the bachelors. Again, that's not in their paper. Here's pre-specified proximal occlusions, big proximal occlusions. Look at this, MRS 0 to 2, 23% MRS in the IVP. You tell me that's not significant. This is his own conclusions, that they started using CT angiography, increased over the course, of course, and the higher recanalization, both arms for MCA occlusions, but the larger vessel, the carotid, TNL lesions, and tandem lesions showed greater recanalization. And most important of all is which devices were used. The primary device is the Mercy, and they only received TK2B3 in 23 to 44% of all patients. That's horrible. And the both Swift and Treehole have higher recanalization rates. This is their slide. Solitaire, 5 total solitaire devices used in the trial, 5 out of all the patients. Let's look at the data from Swift. This is the Swift trial that they did. Of course, it's a company-run trial. But let's look at their data. Just look at their data alone. Solitaire, recanalized and randomized. So successful recanalization higher than Mercy. Recanalization device higher than Mercy. Everything is higher than Mercy and good neurologic outcomes. So we know already that the Swift trial, a more current and modern trial, well, not modern trial, but a more current trial, shows the exact opposite what IMS is doing. This is one of my cases. This case would be god-awful in the old days. Mercy wouldn't work. Penumbra, it probably could. But this is with a pass of a 6 by 30 and then a 4 by 20. So 2 passes with the device and it's open. 1 pass with the device and it's open. This one here is an interesting case. You got clot in the M1, and if you look, there's stuff also in the A2. So I'm thinking, well, I'm going to have to go back. I'm going to have to probably use multiple, but I go up, there's a solitaire. This is post, and everything's open. Even that A2 is open. Well, the reason is because that thing, the solitaire caught the clot that's in the M1, and she was a patient with AFib, so that clot extended and went up into the A2. So it actually caught the big, long piece of clot that was there. And there's more modern technology, distal access catheters, the DAC, the Navion, and the use of these devices has shortened the procedure time markedly compared to what these other trials were doing. And one other point from SIR, which no one had thought of. If you are giving intra-arterial TPA, people do use inline filters when they're administering a TPA. Well, it turns out that some filters absorb 99% of the drug. And that's not reported in the trial. So we don't even know what filters people may have been using, or if they are using filters. And if they're using these filters, those patients didn't get anything. How about MR rescue? Okay, only 124 patients enrolled. Mostly, again, Mercy retriever with some penumbra. Again, the trial did show that there was better outcomes with revascularization. Because if you successfully revascularize 35% of the penumbral and 25% of non-penumbral patients, they had an MRS of less than 2. So even in their own paper, if you look at the ones that did get the proper treatment, index treatment, and the proper device, it was better. IV TPA was withheld from all patients in the endovascular arm. And a basic head CT, again, was used to enroll. So NIH, again, if it's a low NA score, it's a low likelihood of having a large vessel disease. And the patients who in the endovascular arm, which were most likely to benefit from TPA, did not receive it because they're the ones who have distal or small clots, while those in the medical arm did. Therefore, this bias in favor of the medical group. And the synthesis, if there's no large vessel occlusion, IA-TPA, was given into a vascular distribution thought to be a problem. I don't know how you run a trial where you're actually administering a drug, IV or IA, TPA, just because the patient may have right-sided weakness and you suspect there's something in the left MCA, M1, M2, ICA, but you don't find it on angiogram, but you're still giving the drug. I don't think anybody run a trial like that. I don't know how it passed, but again, this is an Italian trial. That would not have passed in the United States. So the paper could easily have read the vascular treatment is equally efficacious. And let's go look now at some of the rebuttals. Mark Chimowitz, who is a trialist, a very good trialist, and been involved in all of these, look at the natural history of the patients. We're only getting to 5% of the patient population that are enrolled in these trials. 95% of the patients aren't even getting to be basically qualified. So it's a small number of patients. And we don't know if these patients may be able to get endovascular treatment, a stent retriever, outside of the window of this, because these are all the trials. And his bottom line is the decision by Medicare to place moratorium on reimbursement for endovascular treatment outside of randomized trials would facilitate recruitment in these urgently needed trials. Well, his game is to put people in trials. That's what he does. He runs trials. Of course he wants everybody to be in a trial. And there is a trial that's getting underway. This is the newest generation, the 3D separator. And the therapy trial by Penumbra is being started right now. We received approval to be on that trial. So we'll get the site visit next week, and hopefully we'll be enrolling in this trial to prove, again, that endovascular treatment is efficacious. And the last thing is Joe Broderick himself was coerced to write a basic rebuttal into stroke. Now, this is not in the New England Journal of Medicine, but in stroke. And you can read it with me. This is what he says. Data from IMS-3 and synthesis cannot address the role of thrombectomy devices beyond the therapeutic window, and future randomized trials are needed. Okay? These trials should include reimbursement by CMS and commercial insurers for patients treated with thrombectomy devices. So he is advocating that we continue the reimbursement, and we strongly recommend that insurance companies continue to reimburse for TPA ineligible patients treated with endovascular within the 4.5-hour window. So those patients who can't get IV TPA, those patients who we know are post-op or on Coumadin or have blood problems. So he himself is still advocating that we use endovascular treatment, and again, we need to continue and use some of the newer trials. So the conclusion is, don't jump to conclusions. Don't judge too quickly. This is just kind of a basic, again, that we're less than 3% of being treated. But the basic conclusion is IMS-3 and synthesis studied IV eligible patients only. EVT should not be withheld from IV ineligible patients or refractory patients on the basis of these trials. When IV TPA eligible patients with confirmed vessel occlusion were analyzed, confirmed vessel occlusion, large vessel occlusion, as a pre-specified endpoint, IMS-3 actually did have a positive clinical outcome. So this is not the end of endovascular treatment for stroke. Really, it's just another and new beginning of the newer devices, and, you know, technology marches on. We are doing things better and faster than we ever have, and the basis of these trials should not thwart what we're trying to do. Thank you.
Thanks. So we have time for some questions. If I could ask one of the first, what imaging are you doing at Methodist for people who come in with acute symptoms of stroke?
Well, I think we do things a little bit differently because we get basically a CT, seen by a neurologist, and we get a CT scan. And because we are in tune to endovascular treatment, our neurologists still aren't even not paying attention to the trial, but we know what we can do. So if they're in that 3-hour or 4.5-hour window, they will get IV TPA. We'll still get a call and say, if they're not getting better, be ready to come in and go after something. And sometimes if they're not eligible for IV TPA in that window, surgical patients, Coumadin, whatever, we just get a call immediately. We do not do any other imaging. We just go do an angiogram. If there's large vessel occlusion, we go. When we're on the trials, which we are going to be on the trial, we follow what the trial protocol is. So the therapy trial will include imaging that will try to prove large vessel disease, and we will follow the protocol. But on a daily basis, we try to speed things up. CT, if it's negative and they're in that 3-hour window, they get IV TPA. If it's something that's ineligible, we go.
Anybody else have questions? Well, I'll ask
Okay.
another one. So in Houston, what's the current bypass in Houston? How does it work with comprehensive versus the primary stroke centers?
Well, I wish I could, we're on the street where there's 3 stroke centers side by side by side. Herman Hospital gets the majority of the acute strokes because they are the level 1 trauma center and EMS is attuned to bringing patients to their hospital. We get some of the strokes because of the hospital-based system. We get strokes because it's a pretty big system, so we're second on the street. And then St. Luke's is not. St. Luke's does have comprehensive stroke, but they're not getting as many patients as we do. So basically, it's Herman and us that get the patients, and we're the comprehensive stroke centers. The other centers around the immediate area of Houston are going for a stroke center certification, but none of them have the complex ones that Herman's got. We're on DNV, so we're not JCO. So we have the DNV one, and I think Herman has the JCO one.
Cool. Anybody, other questions? No? Well, thank you very much. And the good news is Jane's here. And interesting text message. So we'll go back up on the agenda to stroke education. Do you have a slide you wanted to talk about with Homer on how we might move forward? Yeah, this is it.
Yes, sorry, we were playing electronic hot potato with that, and so it took us a little bit to get it here. My apologies. Can you make that any bigger? Make the font bigger? Yeah. Yeah, now I think people can see it. Can y'all see it okay in the back there? Okay. HD, this is your show.
This is a compilation of our thoughts and stuff, and we'll just go over it right quick. The Stroke Committee may recommend to Department of State Health Services through GTAC a number of continuing education hours for pre-hospital providers. GTAC may recommend to DSHS a desired number of continuing education hours. We had talked about 4 hours related to stroke. These hours would be a part of the current required continuing education and not additional hours. For example, paramedics now are required, I believe, 144 hours every 4 years. Of those, I think 36 are what we call additional approved hours, and that's where these would come from. So it's not more CEs, it's just turning the CEs we have into a little more productive help for us. Current continuing education programs may develop content useful to the general EMS population or as a specific medical director-driven program. In other words, this is not intended to interfere with anybody's program, but to actually get everybody on the same page. Let programs that may be driven by the medical director for the service, he can determine the type of things his service needs as far as CE for stroke and implement those into his program. Is that basically, so we're trying to make this as easy to fit as we can for everybody in this type of CE stuff. The EMS medical director may determine the course content requirements for their services. We're not going to set, for example, a basic, you have to have A, B, C, or D. It's like, what do you need for your service in your area and so forth. CE courses could include following, and these are things that we've talked about and suggestions that have been made: a basic stroke recognition, CE, a treatment on both basic and advanced levels of stroke care. Trends in stroke care, that was brought up as things are changing, and we could, that of course would, I think, have to be adjusted every few years to be current, but it would give us a direction things are going. Anything else that we deem helpful in the care of a stroke patient, it's whatever will help us to do a better job pre-hospital. Implementation would be done by DSHS policy change and would not require rule change. Everybody's asked how long will it take. It's difficult to say. What would you go out on a limb with us?
And give me a saw to cut it off behind me.
Oh, no.
No, we just need to make a policy change where, say, 4 hours or whatever the GTAC would recommend that we include would be related to stroke. We would need a way to track that in our database. So we would need to make some sort of an adjustment there. We could start it. We would need a given start time so that we could communicate that out to the individuals and the providers so that they would know that this would need to be incorporated into anyone who's recertifying, say, and I'm just going to throw out January 1, 2014. Okay, say we started this January 1, 2014. Then anyone certifying after that time would need to show that they'd had 4 hours of continuing education related to stroke. That'd be it.
So, yeah, so, do you have, so Homer, this is really good. Do you have thoughts on how your committee wants to proceed? Do you want to move forward with this and then make recommendations?
Well, as I think we're ready to go. This is not rocket science. Stroke care is we've all been kind of exposed to it. We're kind of trying to concentrate a little more on it and make sure everybody across the board is getting the same type of quality information. And I think that the process, as Janie's explained, is going to be simple. I think, albeit there will be some work involved, but we will, in a reasonable time, be able to implement it. So I think we're ready to go with it, unless somebody else has.
Other comments? Is there anyone here from the Education Committee today? Because I think it also obviously needs to be coordinated with the Education Committee as well to get their feedback in a mutual way, and then it would move forward to the general GTAC Council. So if I could task you, let's come up with some specific recommendations next time, and then maybe we can vet them with the Education Committee and get everyone's input on them to make sure that it's not onerous and also has the effect that we want, which is basically for first responders to think fast.
Yes.
Right?
Yes.
Okay.
Very well. We can do that.
Thank you. Next up is, some of you may not know, but the committee structure and meeting times is in flux, and I think rightfully so. People are looking for ways to make it more efficient. And in that regard, there have been a group of recommendations that have been made as to how we might redo the meeting times and structures of GTAC. That is to go from 3 days to 2 days, and to do it in such a way such that people from places like El Paso and other places could get here and get back home within a reasonable amount of time. Oh, wonderful. There are 5 options that we can choose from, and we need to make a recommendation back on which we would recommend. I obviously have some biases, as probably everyone does, but I would like to put it up for discussion, what you guys think. It can basically be divided up into, if you go to the overview these are the individual plans. Here's the overview. Basically, it's day one when it begins, such that people could get here from far-flung places. And then I think the other important part is day two, when things end so people can get back. And then it makes the committee meetings shorter, almost all of them to 1 hour, which if you're not getting something done in an hour, it's not a good meeting anyway. And then whether lunch is involved or not. Does anyone have comments or strong preferences they want to talk about?
We have someone that wanted to present another alternative.
Okay. Well, I think they're, I can tell you my thought. I think 1 hour meetings are reasonable. Beginning it later on day one so people can get here, and ending it on day two early enough so people can get out. I'm actually a proponent of Plan A. I don't know what other committees have been a proponent of. But we do need to have a decision on which one we want to recommend and go forward with. So,
A.
yeah, A. Anybody else? So I'll make a motion for A. Is there a second? Any discussion? Jane, what are the other committees? What have they been recommending?
Well, you're not quite through.
Oh, sorry.
You need to do a rank order file, please, from
Oh,
one.
right.
Okay.
Right, okay.
Sorry.
Oh, geez. I just have to make it complex. How many ranks do we have to do more than, can we do just 2 or 3? How many do we have to do?
Well, the chief asked that you rank 1 through 5. So from your first and primary selection to your least.
So does anyone have a least favorite?
I think going in order that it's in, just 1, 2, 3, 4, 5.
That's, I think E is
Times
definitely
and stuff.
number 5.
5 is the least favorite?
Yeah, E is.
Yeah. Any other discussion? Okay, I will second your motion now. And any opposed to just ranking them in order, A through E? None opposed. So our position will be A, B, D, E. I'm sorry, I should have said A, B, C, D, E. Don't know why the C left me.
Would this new start in August? Did August
Oh,
meetings?
yeah, that's a good question.
Part of the plan was to pilot it in August, whatever comes out of this, to do a pilot in August. I don't know if that's still the plan. That'll be determined on Friday.
And do we know which order, I mean, the committees rotate, the different A, B, C, D, E, so we don't know which time slot we would potentially have.
At this time, no, that's correct.
Okay.
And the other questions that have come up are what days of the week if we went to 2 days, what days of the week are we looking at? And the discussion last in February was, I think Wednesday, Thursday was the most favored 2 days versus Thursday and Friday. We didn't get a whole lot of traction on Monday, Tuesday, I don't believe.
Thank you.
So, and still that is to be determined. I think once they determine what's the most palatable schedule for everyone, then I suspect that they will determine which of the 2 days it would be and then pilot from there.
Okay. And maybe we could do that with a Survey Monkey. Well,
As,
a Survey Monkey to get people's idea of what days they want.
oh, what's days? Yeah.
Right. Speaking of Survey Monkeys, you may have received one from Ron, and this is sort of Iraq surveys and stuff, and unfortunately, because of his DNV review, he couldn't be here to go over that, but we'll continue to do these very small, hopefully that put limited weight on the racks to get some information back on how we can best help them. The ninth agenda item is we have a new company, Health Care Facilities Accreditation Program, that wishes to become a recognized accreditation organization for certification of primary stroke centers in the state of Texas. Is that correct? So previously what we've done is our criteria is based on Brain Attack Coalition and equivalency to the Joint Commission. Because of the open committee rules, we haven't been able, and not wanting to go through all the rigmarole of having open meetings for this, what we've done is we've split the committee in half to review half of the data and then half of the submission, and then come back together with recommendations to see if they meet the criteria. I would propose, pending what Jane says, that we do that again, and pending any discussion of the members present.
As long as those work groups don't make a quorum of your committee.
Correct. And so if it's
Right.
50%, it's not a quorum.
Right.
Right. Right. So I think we can jump through the hoops. That's the way we did it last time, and was pretty. And we could do that in a rapid fashion. And what I would recommend is that I'll just arbitrarily group people in half. We'll send out the information and the criteria, and then we'll set up some calls where we can have a call discussion and then bring it back to the next meeting, so we can put a recommendation forth at that time. Is that acceptable? Anyone have any ideas, discussion, thoughts? Okay, so that's what we'll do. Okay, there's something else. Okay, now we're open for general public comment. Are there any public comments at this time?
Actually, I have a report.
I'm sorry. Please, Deb.
I'm Deb Modes, and I serve on the American Heart Association Southwest Affiliate Stroke Advisory Committee, and just wanted to update you on what we're looking at and what we're working on. And actually, the Southwest Affiliate includes Arkansas, Colorado, New Mexico, Oklahoma, Texas, and Wyoming. And the purpose of the committee is just to address and to advance priority stroke initiatives in the state and in the region. And through our discussion, things that we've identified as issues include like a post-discharge for our patients. We feel like a lot of our patients go home and they don't really know what resources are available and maybe don't feel prepared, as prepared as they would like to be. So one of the things we'd like to do is start pulling together some resources as far as what people have to give to our patients, and then maybe put those on a website and make them available, especially for rural areas who may not have as many resources available. And then also just to let people know, where there's therapy that they could go to, what places have support groups, so those kind of things are what we're looking to put on this website. The purpose of the website is to be able to print off the information, either refer the patient to the information and or have the providers print off the information and give it to the patients when they go home. And then another recommendation we looked at was the follow-up and secondary prevention. A lot of the patients are only there for a very short period of time. So looking at ways that we could try to keep the patients maybe a little more engaged in their secondary prevention. So, we're not real sure. These are just things that we've started to discuss, but I would really like to welcome anybody who has any thoughts or ideas to send them to me, and then I can share them with the group. And Basically that's it, but more looking at post-discharge and then secondary prevention for patients, stroke patients.
Thanks. Next, general comment.
Good afternoon. My name's Scott Christopher. I'm from Nacogdoches. A couple of things on the schedule change. One is I would ask the subcommittee to solicit stakeholder input on your decision making on which option you like the best, because I think there may be more than one options out there as opposed to just these 5. Can you back up 2 slides? Because I got an option I'll throw out there to you. Okay.
Yep.
It's kind of the comments that I've heard in a couple of the committees in the last 2 days are travel. Okay, and you pointed that out. So an option that I was going to throw out there is on day 1, start at 11:30 in the morning. That would give plenty of time for people to fly in that morning. Okay, start at 11:30 in the morning. Go from 11:30 to 12:30 with this GTAC blast-off meeting, and then I don't know what's magical about 60-minute meetings and 90-minute meetings. Okay, so let's split the difference and call them 75-minute meetings. Okay, so make all meetings 75 minutes. So if at 12:30, when the GTAC blast-off meeting ends, you would do 6 75-minute meetings. That would end at 8 o'clock on day 1, not day 2. Okay? Because I don't think nobody wants to be here at 8 o'clock on day 2. But most people that I've talked to don't have much heartburn about having to meet till 8 o'clock on day 1. So you would get 6 of the subcommittees done on day 1. The morning of day 2, start at 8, finish up the other 4 subcommittees, and that would end at 1 o'clock. So now you got a choice. You can either stop for an hour and eat lunch, come back at 2 and go 2 to 4, then finish up the main GTAC meeting, or just work through lunch, start the main GTAC meeting at 1, and you're out of here at 3. Okay, which addresses the travel issues of getting home the same day if it's day 2. So it's just an option. As of probably 10 minutes ago, Dr. Rutledge, I emailed that to all the council members and all the committee chairs, that template, if you will, just for consideration. One last comment as far as picking which day of the week we're going to do this schedule change. I strongly encourage the stakeholder input / survey monkey, how you want to do it, to get that information, because there are other organizations that have meetings this week that have contracts with hotels that would be impacted if we went to a Monday, Tuesday kind of thing. Like the Trauma Coordinators Forum, they have a contract with the Embassy Suites for Tuesdays. So that it's just, I know GTAC's got to do what it's got to do based on what GTAC wants to do, but there are other considerations I would ask.
Okay, I'm happy to put this forward as, a recommendation from the floor. Are there any other comments or recommendations? Because I think travel is one of the biggest issues, and I can't put everybody up at my house, so a hotel may be an issue too. All right. I have some late breaking information. In regards to legislature right now, if the proposed state budget survives, the Texas Council for Cardiovascular Disease may get $500,000 for stroke STEMI data collection, and so we'll see how that works. Obviously, it's ongoing as we speak. Next up, we still have outstanding, Dr. Grotto was going to speak on his recommendation for possible recommendations for bypass. And I would like to, since we've already made that invitation and he couldn't make this meeting, I would like to extend that to next meeting if there are no objections. Okay. All right. Are there any other things right now to discuss? Anyone else has a discussion issue? I have one small thing. I can't make the council meeting tomorrow. Is there anyone that would volunteer to take the minutes of our meeting? If not, I'll give it to Jane. Gone. Okay, so I'll have to give that to you, Jane. Sorry. Okay, perfect. Thank you. Well, that's it. Once again, thanks to Dr. Klosnick for coming. It was very interesting, and we'll see you next August. Thank you.